I'm going to talk of something which in fact continues pretty well of what the previous speakers spoke about. Well, as she said, we came from a time of very early mortality and very high natality. And with time, with the evolution of our Western society, we came to a time now of lower natality and delayed mortality. And that is something which is going to be a problem. When you see, this is data which already a couple of years ago, you see the percentage of individuals over the age of 65, which will be in our societies now and in the future. And you see that there is a marked evolution. By 2025, you see that only in Europe and North America, a great proportion of population will be over 55, which will be over more than 20% of the population. But even in emerging countries like China or South America and South Africa, this is the case. In 2050, 50% of the European population will be over 55. In the US, 80% of people over 65 have one chronic disease and 50% have two chronic diseases. 59% of individuals over the age of 65 are affected by osteoarthritis in the US. Aging alone will generate an increase of more than 30% in real per capita healthcare expenditure by 2030. 30% is a lot of money given the bleak economic future that we are predicted for the moment. And the problem is that it isn't a very, the aging is of course a curve, but the expenses is not the same curve. There's a highly differential distribution of healthcare related to aging, and it's heavily skewed toward the early population. The cost per capita increase gradually up to 55, 65, just skyrockets after and explode after 85. This is the total expenditure for healthcare in Europe between 1996 and 2005 compared to the US. And you see that in about every country it has augmented in an important way, apart some exception, like for example Denmark, where in fact it seemed to have more contained. But that's about the only country where this containment exists. And when you see the health expenditure for individuals in the European Union's member states, males and females, according to age, you see that there is, it's in all those countries, you've got a steady increase and then an explosion after the age of 75. And there is a difference between males and females. Is it because women are less sick than men, which would be nice for them and bad for us? Is it because they have less access to healthcare, which will be very, very bad for everybody? Because when you see the difference between the new European states, which are here, this is, I would say, the emerging Europe, Eastern Europe, Southern Europe. And when you see all the 15 original Western European states, you see that the trend is exactly the same in the newer than in the older, but with, of course, less absolute money. You see here the values and the difference between men and women in the 15 original countries, and here the emerging have the same curve with, of course, less money per capita and a higher difference between males and females. So this should lead us to ask us some questions. Back pain. What is the prevalence of back pain in the world? Well, it's not much different from the A region, which is Western Europe, United States, Canada, Australia, and so on. The new Western European countries, for example, the Western Pacific region, excluding Japan and Australia. You see that we have the prevalence of back pain augments exactly the same way in all three regions in men and women. The causes of chronic back pain in Europe, well, the causes of chronic back pain in Europe, as far as region is back and specified, lower back, neck, so you see that upper back, you see that back is more than 50% of complaints. And as far as diagnosis is concerned, the biggest diagnosis is arthritis, whatever that means, or then herniated disc before traumatic injury. And when you look at the different European countries, well, you see that we've got exactly the same type of development in every country in Europe with little difference, but not very much. We have the arthritis, osteoarthritis as first reason for pain, as the second one being herniated disc or deteriorating disc. Who had back pain last week in Europe? Well, it's very simple. You see a million people. This is not percentage of population, but absolute number. Well, you see in Belgium, 1.9 million people out of 10 million had back pain last week. In Germany, 14 million. In France, 7. In the UK, about 10 million people had back pain last week. Well, it's a kind of important disease, if you can call it disease, which I'm not sure. The disabled workers, and these are data compiled from the US and some European countries, well, you see that respiratory condition seems stable, circulatory conditions are diminishing, and musculoskeletal conditions are growing very much. The aging spine means that the delayed mortality and better control of life-threatening disease means that new challenge will not anymore to have patients getting older. The patients are pretty happy now to live until the average of 85. They just want that the last years of life which have been given to them by the augmentation of lifespan will be in good quality. So next frontier is going to be the quality of life. What our population expects, elder subjects will demand and will expect that we use all the available technological tools that we have to give them a better quality of life. And new complex measurement instruments have been designed like QALY and DALY. As you see, life expectancy has augmented slowly, then more rapidly, and then came to a plateau. To have now a small increase of life expectancy would ask huge resources. So really quality of life will be the next frontier. Back pain and neck pain are among the most frequently encountered complaints of older people, but the relation between aging and the degenerative process is really not very clear. We all will have wrinkles. Everybody of us will have wrinkles. That is normal degeneration process of the skin. And we all will have degenerative spine. We will not all have osteoarthritis of the hip or the knee. No, but we'll all have degenerative disease. I'm not sure. It's just an aging. And in some cases, it's too much. And in the spine, it's too much, and it becomes, as you see here, a stenotic condition. The multifactorial nature of spine degeneration, the complexity and the multiplicity of treatment, the rapid evolution of technology and nature of patient expectation, very important patient expectation, well, has resulted in an escalation of cost in our field. Can we cope with that? Look, in osteoporosis, osteoporotic spine, I'm not going to come into detail, but you know the fractures, osteoporotic fracture, the prevalence is about 39% in subject over 65, and it is associated with increased risk of death and diminution of quality of life. It used to be a cheap pathology. Well, there was no treatment. You get over-the-counter drug. Now, it becomes a very expensive pathology with all kinds of surgical intervention like kyphoplasty, which cost about £4,000, or preventive expensive drugs like parathormone, strontium radiolate, and so on. So we have improved people's quality of life and health, but at a huge price. Treatment will cost more and more. And in the future, it will even cost more and more. We'll have to show that we can show our efficacy in our field, because we are going to have competition between different medical disciplines for a share of the limited resources, and this discipline, other disciplines have quite extraordinary results in cardiac surgery, for diabetes, for other types of pathologies. We see real breakthrough. We didn't see much real breakthrough on spine. So this competition will be bad. And even, as I said, compared to the evolution of cardiovascular disease, diabetes, cancer, the treatment of spinal condition does not appear to be such a priority, which is wrong because, as I show you in a few minutes, it has a high impact on the life of people. And there will be also competition between the different treatments of our own field. I mean, when you see results of total hip replacement and results of disc replacement, well, for me, for the moment, there's no photo, okay? It's totally uncomparable. And of course, there will be competition with other social security resources, like retirement. In most of our Western countries, not the US, little less Britain, but most European countries, retirement system is based on a collapsing system due to aging and unemployment. It's a repartition system where younger payers pay for the retirement of older payers. Well, no democratic country can afford to see its retirement system collapse. That will be a revolution. They'd rather take money for the healthcare to put in retirement. And they will, believe me. And as I said, we even compete in our own field with other resources, other treatment, which I think help people maybe for the moment a little better than what we do. So we have competition in our field against a lot of people and a lot of things. We talk of failed spine and the spine surgery, and there are at least 2 books about failed spine, one by Scott Bowden, the other by myself and Robert Ginsberg. I'm sure there are more. We don't talk of a failed hip. You're told of a loosened hip, infected hip, badly inserted hip, but not on a failed hip. Failed spine, we have people who have perfectly operated, the images are perfect, everything is perfect, and they really still complain. You don't have that in hip, you don't have that in knees, but we have that in spine. We have a failed spine syndromes. We have numerous and expensive technologies and scarce evidence, often poor quality of studies. Not only do we have to fulfill the expectation of the patients, we have to fulfill the expectation of the healthcare field, of the government, insurance company, of those who pay for healthcare, and who will not follow forever an increase of cost without showing real efficacy. It is here now, discs, non-fusion stuff, fusion for low back pain. In US, Blue Cross Blue Shield, not Blue Shield, Blue Shield, which is the biggest insurance company, denies actually coverage for fusion for low back pain in about half of America, and it's coming elsewhere too. And there the science fiction. This is what was projected by some analysts on the US spinal market in 2004. By 2010, 50% almost with total disc replacement, 28% dynamic posterior stabilization, 20% disc nucleus fusion, we have 5%. Those were very serious analysts with QALY brothers. Well, the disc replacement has about a 2% market share now. Fusion rates have risen very fast in the US with patients with spinal stenosis, 20-fold increase. However, very interestingly, this is the overall rate of spinal surgery in the US. You see also a higher number of lumbar MRI spine, opioid analgesic prescriptions. So we do more exams, we do more surgeries, but we prescribe more opioids, which seems that our surgeries and our exams and things don't seem to be extremely efficient. The surgery rate is a high augmentation, and you see that when cages were approved by ADA here, intravertebral cages, the number and the amount of surgeries just skyrocketed afterwards. So the fact to have that's not very interesting. The fact to have devices helps us and pushes to operate. Also, in different parts of the US, and I'm sure the same will be in Europe, the amount of spine surgery goes from about 25-fold, 20-fold. Are people really more sick in some places than others? And the same for fusion. Fusion is the worst. Different region of the US, well, you have a difference of rate of spine surgery of fusion of 40-fold. Some regions operate 40 times more than the others. Is back pain a communicable disease? Well, it might be. When you see East Germany and West Germany, in 91, 92, there was a difference of prevalence of low back pain between West and East of 12%. In 2003, in only 10 years, there was only 1% difference. East Germany had 13% less back pain in 90, and they have the same back pain now. So probably it is somewhere a communicable disease, and it exists in the whole world. Development level, when the countries get developed and things change, I will say, you see for the moment, the developing countries still have a much lower complaints back pain rate than our countries, but even if you see in India, I have here, in China, I have here a number, there is a huge difference between rural China, where 12% of men report low back pain and 28% report in urban areas. So there is some kind of communicable or at least link between back pain and development. Charles Dickens said 150 years ago that nothing really looks like everything on evidence, there is no better rule. And after many years, our governance came back to there and established health technology assessment. I think Norbert Busen, who is sitting here somewhere, knows that better than me, but nevertheless, every country has a health technology assessment center or administration. I pick the biggest one I pick in Belgium because that's the one I know. When it was established 10 years ago, we all laughed, saying, hey, government assessing health, that's going to be fun. Well, they did a bloody good job, and it's not good for us. It will become more and more pervasive, and it's not good for surgery because the techniques of 88 as applied now are mostly those taken from drug research. And drug is simple. There's only two ways to give drug. You swallow it or you inject it. And there's not 100 ways of swallowing or injecting, but there are 100 ways of operating. Pharma HT is simple. The drug from prescriber is the same drug given the same way. From surgeon to surgeon is not the same thing. And from it might be more difficult to operate, less difficult. Patient, it might be a good day and a bad day. It's very difficult to assess a surgery. Just 2 last minutes, cost-utility analysis. That is something which is going to be on our head in the next 30 years. That is what governments are going to use. It's a variation of cost effectiveness. It considered patient preferences for the therapy. The type of analysis measures outcome in units that consider the utility that the subject himself plays in his quality of life. And the most known is the QALY. The QALY is a quality adjusted life years. It's a measure of disease burden including the quality and the quantity of life, used to assess the value for money of a medical intervention. It requires independent, risk-neutral, constant trace of behavior, and the QALY is 1 year without disability. It's very simple. A kid would be ready to give 10 candies for a 10 centimeters bar of chocolate and 2 candies for an apple. If we choose the bar of chocolate as a utility, well, the utility of the chocolate is 1, that of a candy is 0.1, that of an apple is 0.2. That's the way it is measured, basically. There are a lot of ways to do it. The VAS, where you say, what is my health perception? But more used are the time trade-off, which means you compared your actual health status and the same number of years, and the number of years with your actual health status, with years in perfect health, and you see what you prefer. Well, do you want to be in perfect health for the 20 next year? Oh, yes, thank you. Where do I sign? Do you want to die now? I'd rather not. Do you want to live in perfect health for 18 years and then die? Would you give that trade-off? Well, I'll think about it. If I have huge pain, maybe I'd accept to die 2 years earlier to have 18 good years. Well, that's about how they measure. And there are 4 types of QALY, four possible results. You may have here something which would be less costly and more effective. Well, there is not much in there, less costly and more effective. Then you have more costly and less effective. And here there are some technologies in there. And then you have what is usual, more costly and more effective. It could be very much more costly and a little more effective. It could be a little more costly and more effective. And that's what we have. But maybe one day the government will say, well, let's have something which is a little less effective and much less costly. And that's something which may happen in the future. Well, as I said, low back pain shouldn't be underestimated. Low back pain is here. Chronic back pain, as impairment of quality of life is more than non-oxygen dependent chronic obstructive pulmonary disease, more than end-stage hemodialysis, more than physically disabled adult. Over low back pain, chronic back pain, there's only oxygen-dependent COPD, chronic pain non-responder, and amyotrophic lateral sclerosis. So back pain has an impact on the quality of life. Let's look at stenosis to finish. There was the Good Sport study made by Jim Weinstein in the US, which showed that the compressive laminectomy versus conservative treatment gives good results at short terms and at longer terms. Patients with symptomatic spinal stenosis treated surgically compared to those treated non-operatively maintain substantially greater improvement in pain and function through 4 years, which is good. But at what price? Let's look at that. Well, it's very simple. If for spinal stenosis, if you just do a decompression, it comes at $47,000 per QALY per year. If you do a fusion, it comes at $258,000 per QALY gained. So you might think that this difference, which is not reflected in the results, the surgical results, will tell our payers that maybe someday they say no fusion, except in some cases. For degenerative spondylo, there's also a difference, which is smaller. $40,000 for decompression alone, $120,000 was for decompression surgery. That's not the cost of surgery, that's the cost of one added quality life year. And I remember the Scott's parabola, where you have a promising idea and it might be interesting, and then it becomes with a strong media pressure, and then becomes general standard, and then there are some doubts, and then damaging surveys, and then you begin publishing medical legal cases, and the same media who wanted it are beginning to pound on it, and then it's been condemned, and then only highly specialized disease circumstances then falls into disease, and then the operating theater staff ponders why we have all this stuff which nobody ever uses, and then finally very old surgeon will amaze their young colleagues are saying, when we were young we were doing that. And beware of computers in orthopedics. Thank you.